I want to thank Jacob Kirsch, who just presented, who is really the driver of this study. These are my disclosures, mainly DJO and diffuse synthese. So I'm essentially reiterating what the last two speakers have said. RSA indications have greatly expanded since the 2003 IDE of DePuy Delta, which was for rotator cuff arthropathy. But some props to John Levy, our co-chair here with Mark Frankel's work, showed how reverses do extremely well for hemiarthroplasties for failed proximal humerus fracture treatment. And then Derek Cuff then published with Mark Frankel's work, 2008, for massive cuff tears without arthritis. And then probably the most prominent one after that is Mizuno with Walsh's data looking at reverses doing well for B2 glenoids and OA. But the reasons we don't really understand who does well and who does poorly is what Dr. Friedman pointed out, is a lot of the literature is confounded because when you look at the methodology of almost every paper out there looking at reverses, it includes rotator cuff arthropathy, massive cuff tears, primary OA, just to make the numbers bigger. So it really confounds who does well and who does poorly. And as both Dr. Friedman and Dr. Kirsch have pointed out, the outcomes differ by diagnosis. And so actually this is one of Dr. Friedman's papers, but when you look at gender, for instance, you find different outcomes. In one, it had no effect on reverse, and the other one, gender did have an effect. And I think that may be related to our methodologies in these papers. And then additionally, OA is underrepresented. You know, a few years ago, I think it was hearsay to say you're doing reverse for OA, and now more people are saying that openly. And so I think that's going to make our outcomes different as we move forward. So the study question here was, in 2021, what factors predict excellent poor outcomes after RSA, looking at demographics, diagnosis, previous surgery, etc. So to give you a sense of the study population, we collect in our office using OBERT since 2015. There's 780 RSAs done. In the window that there would be 2-year follow-up, there's 515 RSAs. We excluded fractures, chronic dislocations, revisions, AVN, ones that were too small and wouldn't make a difference, and we sort of wanted to make a homogeneous group. So it was mainly OA, rotator cuff arthropathy, massive cuff tear without arthritis. And then we had 82% follow-up with pre- and post-op PROMs, exams, and x-rays, so a large follow-up rate. This is what we collect. I highlighted pre-op opioid use because that's a little bit unusual that we collect that, number of allergies, marital status, and then the PROMs are VAS, ASES score, and SANE. And then range of motion, I measure with the goniometer. I do them at every visit, except my PA has now begun to do it in the same fashion that we do. So it's pretty reliable, or done the same way systematically. So we looked at two groups, the top 25th percentile versus the bottom 75th, and then the opposite, bottom 25th versus the top 75th, using univariate and multivariate analysis. So a very simple study. If you look at the poor outcomes, pre-op opioid use was number 1, previous surgery is number 2 with an odds ratio of 2.7, self-reported depression, the number of allergies, and then probably the greatest odds ratio of excellent outcomes was OA, which we've seen in the last 2 studies, and then private insurance. So the discussion here, I really want to make 3 points. Our surgical treatment algorithm matters. We just had these rotator cuff cases, and we're talking about doing lower trap transfers, superior capsular reconstruction. This is going to have an impact on the reverse down the road when they have it, and there's a lot of literature to support that. We have to be very cognizant of the downstream effects, as Dr. Levine was pointing out earlier. Psychosocial issues matter. I think we know this. I'm not sure we're doing anything about it. We're trying to do more about it in our practice, but previous opioid use and self-reported depression, there's lots of literature to support this, that they really matter in terms of the outcomes, and we really have to focus on that. And then lastly, sort of the theme of this sort of opening session is OA patients have better outcomes, and we should really compare apples to apples, as Dr. Friedman says, and I think that's going to change over time as we start looking at this more closely. Jacob Kirsch just presented on this as well. So in summary, this is a retrospective study of prospective data with high follow-up in large numbers, excellent outcomes in the diagnosis of OA and private insurance, and then poor outcomes with opioid use, previous surgery, self-reported depression, and number of allergies. Thank you.